wa rahmatullah, dear colleagues and friends. Welcome to 8 Al-Qasimi Ophthalmology International Conference, this year virtually, and we are enjoying having a lot of eminent speakers from different parts of the world. And we'll start today with very special session, cataract session, that will be presented by a very eminent speaker in this field. It's my pleasure and honor to start with my dear friend, Dr. Abdurrahman Al-Rayes, and the mic with you, Dr. Abdurrahman, for the first presentation. Thank you.
Thank you very much, my friends. Thank you, everybody. It's a great pleasure for me to speak with you today. And I will share with you my experience about the IOL, the choice of IOL in cataract surgery. And I have some problem. Yeah. So for cataract surgery, this is my plan for my presentation. And we have to make difference between cataract surgery and refractive lens surgery. Of course, in the first case, we have to do cataract for people who are not very demanding. And for the second case, it's for people who want to live without glasses or not to be dependent with glasses. So let's see the evolution of cataract surgery. Of course, during the last year, a lot of things changed in cataract surgery. Surgery must become less invasive, and the IOLs are very sophisticated intralens. So let's see the practical approach. Why patients must be selected? Because in the past, we had a high complication rates and longer rehabilitation time, and always we delay surgery until the cataract was mature. And by this time, due to visual impairments, the patient may have been struggling to function normally. Today, with the new technological developments, different criteria to list to patients for cataract surgery earlier and to avoid interfering with their lifestyle. So how patients are selected? Of course, we have the visual acuity, of course, but also the visual function and quality of life. And for visual function, we have various tools to test the visual function, but also they have other tools like indirectly how to they are living activity of daily living scale, general health, general physical health, cognition, mood. And of course, we have also to ask patients about their activities like crunchman, hunting, hooking, etc. And to take account also for some individual specificities like astigmatism or myopia or hypermetropy to choose the good IOL. So with this, we very important before surgery, before to speak with patient and to ask them what are the visual demands. And with that, after that, we can, of course, we have the exclusion criteria. Like for multifocal lens, we cannot, it's not good for night driver because we have to loss. And we have to take account also for anatomical criteria like myopia. It's not very nice for high myope to do multifocal or toric lens because the lens is not good centration and can turn, and we can have a tilt. And also psychological criteria like to avoid demanding patient and also, we have to take account of pre-existing ocular condition like diabetic or retinopathy or glaucoma or macular degeneration. What are the preoperative examinations?
Download.
First, we have to develop the operative strategy for both eyes. And during the consultation, we have to take acquisition of the image and to check the ability of and order the IOL, and of course operating room programming. So in slit lamp examination, very important, and also the first case we see the topography and to if our patient has the astigmatism or not. Of course, we have to take account if cataract is easy or not. Biometry, of course. New formula with biometry, microscopy, and as I told you, we have to manage astigmatism and type of astigmatism, regular or irregular, the axis of astigmatism, and the importance of astigmatism. And with this pre-op evaluation, we can propose to the patient some IOLs like monofocal IOLs or multifocal IOLs for bifocal for near and distance, trifocal for intermediate vision also, and the more and more EDOF IOLs for extended range of focus, and of course toric IOLs to manage corneal astigmatism. So to resume, we have 3 steps: acquisition, planification, and guide during surgery. 3 steps, very important to be reproducible in these 3 steps. Pre-op evaluation, of course, biometer optical is better than ultrasound, and new formula like Barrett is very important. If you have some reference unit to have for planification, like Varian machine from Alcon or Callisto from Zeiss, we can do planification and have a good idea about pupillometry and keratometry, and we can have reference images, and then we can do planification. Here it's small video to see the acquisition by the optometrist, or it's very easy to have topography. Then after we have biometry, and after that we can check make the analysis of the lens, good centration here. Very important to have the good exam, good centration, good images. We can do a lot of exam, change the topography to topography or to biometry. And after that, we can have the lens and proposition the lens from the machine, like here for toric lens. And it's very personalized technique and depend of each surgeon. So planification here, I am using with Varian platforms, very good, very nice, very easy to use. And you have the target here, the target refraction, and also the expected outcome, the refraction after surgery. And it's wonderful. We always be at outcome. So the current process, it's very important to have a good, to avoid error, to be reproducible in each step during surgery. So also during surgery, you have to make, of course, it's not like a normal cataract. When you have a premium IOLs, you have to take anesthesia. If we have excision patients, we can do local anesthesia, not topical. We can also choose the blue vision or not, micro incision. And of course, with digital marker, we can use femtosecond laser or cataract surgery. And this digital marker, it's in the surgery room. We can have an incision guide for capsulorhexis guide and centration guide. This is here are some photos about incision mode. During surgery, we can have capsulorhexis mode and centration mode, toric lens, and with the alignment of lens and final lens. Here, for me, I always do 3 incision, 2 main side ports, and 1 main incision for 2.2 millimeter. And this is my surgery, and it's very nice. It's very easy to do surgery with the image in the microscope. And of course, we can also do a regular rhexis for 5.5 millimeter more easily with the Varian machine or with the guide than without. And also with toric lens, we can here with bimanual irrigation aspiration, we can place the lens in the good, fix the lens in the good position. Here we have the graduation during surgery, and we can put the lens in the right axis, and also remove viscoelastic on the lens and behind the lens. And after that, in the end, we have to check lens position if it is the good position or not, and good access. So in post-operative control, it's very important to do the verification of the lens without dilatation with machine or in the slit lamp. And also we can do some statistic automatic evaluation after a few cases and optimization for future results. What are the post-op results? Of course, we have better visual acuity and visual function cataracts that improves functioning in everyday life with respect to vision-dependent activities. We have decrease general function, decrease in the rate of falls after cataract surgery. Second, eye surgery can be important in improving binocular vision. And of course, we have better health-related quality of life and better cognitive and emotional well-being. So here are some cases for some lens. Here, VVT, standard-off lens, before surgery aids with astigmatism after surgery. Topography biometry. Here we are an example for bifocal acryl bifocal lens for pre-op and post-op. Very nice results. And trifocal lens, toric lens, trifocal toric lens. We had trifocal toric lens for this patient, both eyes. We have 10-10 without glasses. And toric, okay. So, well, video of panoptics, it's also easy to, it's not so important to show. Is the VVT IOL. I'm very happy with the VVT. It's give me great satisfaction for me and patient. And of course, we have to know each IOL, the limits for each IOL. For example, multifocal lenses are not good for driver because we have the halos and we have less halos with head-off. Multifocal lens require a good light for reading, and also for head-off lens we have to put the lens for reading. It's good for intermediate, but not for reading. And also from time to time we have some patients who will not have a good acuity from so far with multifocal lens. And of course with bifocal lens we not have the intermediate vision. So in synthesis, always think about refractive lens surgery, suggest the intervention as soon as possible, choose the IOL.
We are already behind the time, if you can.
Yes, we have to choose the appropriate selection of the IOL for surgical procedure. And with the advent of this new area of artificial intelligence, it's our diagnostic and measurement devices that will be able to compare the anatomical data of our patients with their lifestyle habits to propose the appropriate intraocular lens for each individual. Thank you very much for your attention.
Thank you very much, Dr. Abdurrahman, for this excellent presentation. Maybe we'll have some question at the end of the sessions. So because we are a little bit behind the time, so at the end we will have a few minutes for discussions. Now we will move to my dearest friend, Dr. Khalid Aish, and he will give us a talk about biometry in extreme eyes. Dr. Khalid, the mic with you. Unmute yourself, please. You can share screen, Dr.
Okay.
Khalid.
Okay, yes. Okay, can you see my screen?
Yes, Khalid. Yes, please.
Yes.
Go ahead.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Thank you for this invitation. For the sake of time, I will start my talk. It's about biometry on the outlier eyes. This means that we are talking about the long eyes, which has diameter of more than 26 millimeter. Short eyes, when we have diameter less than 22 millimeters, including the nanophthalmic eyes, which are the very short eye and the very shallow anterior chamber eyes. The guidelines in 2011 was in short eyes, the recommendation was the Hofer Q. In long eyes, when we have 24.5 diameter to 26, Holiday 1, and in extreme long eyes, SRKT was the recommendation. Is this guidelines still valid in 2023? I think no, because there are a lot of drawbacks about the formulas at that time, because these formulas are based on an eye model, and therefore they need to estimate the implant position for the IOL calculation. And these third generation IOL, like the Hoover Q, the Holiday, or the SRKT, they estimate the lens position based on the axial length and K measurements. And they assume that long eyes as well as steep corneas have a deep lens position, and short eyes or flat corneas have a short or a shallow lens position. So this assumptions is why all of these formulas provide weak performance with extreme eyes, because the vast majority of long eyes as well as short eyes show normal anterior chamber dimensions and are not deep or shallow as assumed by these formulas. And this table we can see that a lot of short eyes have normal anterior segment size, and a lot of even normal eyes can have a shallow or a deep anterior chamber. And also many of the long eyes have even a shallow anterior chamber. So what this explains why these formulas perform bad in the extreme of eyes. And these formulas are based on only two variables. They are based on axial length and in K readings, and they do well in average eyes. But the new formulas, they have an additional parameters like the lens thickness and the optics, and they do better in these eyes, such as long eyes with shallow anterior chamber or short eyes with deep anterior chambers. What is the problem with myopic eye? The myopic eye, the standard refractive index is no longer accurate because there's increased optical pass through the vitreous, and this gives that the axial length is overestimated in these eyes. So this leads to hyperopic surprises. And what are the options to save these problems? They came out with a one-Koch method, which an adjustment for the axial length. And what the one-Koch adjustment, it's compensate for the overestimation of the axial length with the standard biometry. So they reduces the axial length by a formula-specific coefficients. And this, at first, was the guidelines for one-Koch adjustment. Then they have an updated adjustment methods, like they can be used only for SRKT or Hoover Q, Holiday 1, and these are the guidelines that updated recently. But the problem with this is that they avoid the hyperopic surprises, but on the contrary, they increase the myopic errors. And this one-Koch is not required for Haigis, and recently they do not advise to be used also for Holiday 1. And these should not be used with Barrett, Olsen, or Hill RBF methods, and should not be used post-refractive surgery. So the second option is that some other formulas, the newer formulas, that they do not require the adjustment, one-Koch adjustment, like the Barrett, the Olsen, and the Kane, and the Hill RBF. So these formulas can be used without axial length adjustments. If we look at this table, we can find that the Barrett formula do well. This is the diagram showing the axial length. This is the axial length, and if we can see here that the Barrett formula performs very well in long eyes, in contrast to the SRKT formula, for example, or all the Holiday 2 formulas, or even the Haigis. They perform good in average eye, but in long eyes they do not perform that much well. So to summarize, in long eyes, the top three options are the Olsen, Barrett, Haigis. The unadjusted one is doing well, but one to avoid is the Hoover Q and the Holiday 1 formula in long eyes. The one-Koch adjustment is not great because a lot of eyes becoming myopic rather than hyperopic. So using formulas without the one-Koch adjustment is a better options. Kane and Evo also are good options in long eye. So the outcome in long eyes are better because we are dealing with a lower power IOL, and expected lens position has low impact on the outcome, in contrast as we will see in the short eyes. Now for the short eyes that are less than 22 millimeter diameters, Douglas in 2017 came without line of this, where the best outcome was with the Holiday 2 of around 77% of eyes within a quarter of a diopter. The HOFR-Q formulas was not performing well. So where is the error in hyperopic eye? The error is in the expected lens position, because in these eyes we are dealing with a high power IOL like 30 or 28 or something, and even a small shift in the position of the IOL will lead to a high refractive change, in contrast to long eyes where we put a low power IOL. So any shift in long eyes will not affect the outcome as much as the hyperopic eyes. And everyone now, if we say short eyes, then okay, HOFR-Q is the ideal formula. Where this came from? This came from a study done in 2011, and they studied around 8,000 eyes with only 134 eyes of axial length of 21.5. And at that time, in 2011 or 2010, when they did this study, they only used the third generation formulas like the HOFR-Q, Holiday, and SRKT. And at that time, the HOFR-Q was the best formula to perform compared with the other versions formula. Is this still valid nowadays? No, because now we are having better formulas, and the evidence supporting HOFR-Q in short eyes is out of date. In 2016, 2018, Ken and Mills came out that HOFR-Q is one of the poorest formula for short eyes, and they came out that Barrett and Holiday one, they even perform better in eyes with 21 to 22 diameter range. And this is, as we can see here, in short eyes, where we can see the HOFR-Q formula is performing the worst among these when compared with the Barrett or Olsen formulas. In another study, they found that the Ken formula was more accurate and even better than Barrett Universal to Haig's LRBF and Holiday and HOFR-Q. And Ken is another formula that is good to be used in short eyes. So to summarize, the top three options in short eyes, we have the Barrett, we have the LRBF3, and the Ken formula. But we need to note that HOFR-Q is good when compared to Virgin's formula, but it's not good when we compare it with the newer formulas we are having now in 2023. And the performance of these formulas is a little bit worse or weaker than the performance in long eyes, because we are dealing with a very high power lenses, and any shift in the position of these lenses will affect the outcome much more. So when we are dealing with an average eye in terms of axial length, in terms of anterior chamber depth, in terms of keratometry, most of the formulas, they perform well. But when we are going out of the average eyes in any of the three of these parameters, they found that the Barrett retains the greatest consistency across all variables, and eyes with very short axial length, no formulas did that much well. Thank you very much.
Thank you very much, Dr. Khalid, for this excellent presentation. And you make the things that difficult in a simple way. Very nice.
Thank you.
This topic is very difficult. Most of the time, nobody like to hear, but you make it very easy and very concise. And you make it in a very short. Thanks a lot. So we will keep, so if there's any question till the end. The third topics, Dr. Walid available, Dr. Walid Zabiba. So Dr. Walid, he will give us a talk about IOL fixation.
Yes.
What's new?
Okay.
Let's summarize. So thank you, Dr. Walid, for being with us.
Thank you. Okay, I will share my screen.
Please.
Okay. So it's okay.
Yes, please. You can go ahead. We
Okay.
ask my colleagues to mute themselves, please. Okay, thank you.
Okay. So first, let me thank you for Dr. Amri for the invitation. My topic today is about we'll tackle two main techniques that I have used, and I will mention the benefit and the drawbacks of each one of. So as you well know, the loss of capsular bag is a challenging issue. The surgeon to decide the type of the IOL he should use. This situation could be the complicated cataract surgery, IOL exchange, and substituted IOL. Several techniques and IOL are supposed to correct this condition. In order to settle a stable IOL, maintain the normal eye anatomy, a good functional outcome and decrease complication rates. We do have 3 options for implementation. IOL, iris fixation implants, and the well-known scleral technique. Today, we're going to focus only on commonly used option, which are the scleral fixation, since it seems to physical state because to the eye nodal point, and there is a minimal endothelium cell loss. And that reduces the risk of the ocular aberration in the outcome. The rapid rise in technology and wide degree in fixation have been provided, but when shed light on worldwide used Yaman modified commonly performed and the recent one Carloval technique. The Yaman technique was in 20 modified in 2017 with different varieties. We use 3-piece intraocular lens, the one with the haptics gives the finest stability in the sclera insertion. Called this kind of Carl-Zeiss measure. Now let's make a look. We don't need an expensive tools or instruments for this technique. First of all, we make cornea for introducing the forceps. And pass the needle transconjunctivally 2 millimeters posterior to the left, 180 degrees apart. Okay. After that, we duct into this needle. We put the haptic in the needle of each needle. After that, we draw and the 2 haptics in the side. Exercised haptic ends are met with a cautery, created a bulb shape enter the conjunctiva tunnel. According to my experience, the IOL via the introducing of the facilitate the monitoring of the both haptic and needles. There is this like the absence of contraindication of this and with the standard IOL, no complication related to the suture or the glue, and there is a minimal UV with the eye. Now let's move on the Carloval IOL, which is the lastest method of the.
Dr. Walid, can you hear me?
Yes.
All the presentation there is an interruption in the internet, so most of the things we are not hearing very well, unfortunately. I thought it will make me Hello, can you hear me?
Don't hear you very well. Yes, now yes. There's a
Okay,
problem.
because you have a problem in the internet. We cannot hear you. Most of the presentation we are not able to hear very well. We can, you know, I don't know, because most of the time interrupted, we are not getting the idea or the things that you want to pass to us.
So
If you can, we can have it as a recorded at the end.
how can I
If you
avoid
can
the show?
record, yeah, we are not able because it's very difficult.
Okay.
Hello?
Yes, I can send
The recorded, please. Yeah, I advise to send us the recorded to the email. They will play it from
yes,
here.
yes.
Is better. Okay. So I will, if you
Okay.
allow me, I
I will.
will stop from here and I will ask the other presenters to be given. Okay. Thank you very much.
Okay, we'll do it. Sorry,
Okay.
sorry.
Thank you.
Sorry.
Thank you. Yes. So we are sorry that I thought maybe it will be improved in a time, but it seems there is a lot of problem in the internet with Dr. Walid. So we can move now to dearest Dr. Mohsen Al-Baqali, his presentation. And his presentation, it will be tips and tricks in pseudo exfoliation management. And it is a pre-recorded presentation. Can you please, the team, share Dr. Mohsen presentation?
Bismillah ar-Rahman ar-Rahim. Hello everybody. I would like to thank the Mayom Academy for honoring me twice by associating me with the Mayom board and by inviting me to participate to this session. My talk today is about a common association between cataract and pseudoexfoliation, which can complicate the cataract surgery. We will review some tips and tricks in order to avoid and or to manage the difficulties inherent to this association. It must be emphasized that the cataract and pseudoexfoliation are both age-related pathologies whose frequency and severity are age-related. The combination of cataract and pseudoexfoliation its definite risk factors for cataract surgery, as the complications are at least 10 times higher. The first aggravating factor is the zonular fragility, which can seriously compromise the outcome of the surgery. The preoperative assessment is of utmost importance, whose purpose is to analyze all risk factors, namely the pseudoexfoliation spreading, the poor iris dilatation, iris sphincter atrophy, endothelial cell degradation, phacogenesis and iris dolosis, the anterior chipped variation, especially when we have before surgery decreased anterior chamber, and the narrow angle and the eye hyperpression. And the key of these assessments is to deeply analyze the association to associate zonulopathy. Moreover, the preoperative assessment has the triple goals: to analyze the cataract, to analyze the associated lesion of all anterior segments, and to be prepared to different surgical scenarios, simple or complicated, phaco, and in some situation to do phaco and anterior vitrectomy. The screening of the zonulopathy should be done before before and during the surgery. Before the surgery, a big attention should be given to the above mentioned element: the material exfoliation spreading, the poor iris dilatation, iris atrophy, and we have to focus to assess before surgery the anterior chamber depth. The zonular fragility can be noticed at the beginning of the surgery with the famous sign of the capsular touch, which consists in noticing an abnormal mobility of the bag as soon as we start the capsular exercise. It's very important to notice this sign when starting the capsular exercise because we give us an idea about the bag stability. The preoperative precaution consists mainly to those objectives to protect the ocular surface, to maintain a good iris dilatation up than 5 millimeters. If not, we should use iris retractors, OVD, or other devices, and to protect the capsular bag and the zonula when doing this kind of surgery. The protection of the zonula and the capsular bag is achieved through the following measure: using the OVD to maintain the anterior chamber stability, dispersive and cohesive, to maintain very iris pupil dilatation more than 5 millimeters, to do gentle hydrodissection, and to avoid nucleus rotation in some cases. The main novelty that we describe in this presentation is to show how to carry out of safe phacoemulsification without nucleus rotation. This is done by sculpting to my sculpture of the nucleus into stages. At the beginning in the central, which is classical, everybody will do the kind of when we start to do phacoemulsification in the axis, as shown in the picture number 1, and a lateral sculpting as shown in picture number 2. This can be done by making a rotation of the headpiece without the rotation of the nucleus. This maneuver, it's very helpful to solicit and to make the bag and the zonula more fragile and more weak. This maneuver of rotation of the handpiece avoid the solicitation of the capsular bag, so the handpiece will move laterally as wall clock. And I highlight the fact that it's very helpful in very hard cataract with no stable bag and capsular with the zonular with the zonular fragility. It's very helpful to do this maneuver. Besides protecting the capsular bag, we focus on the fact that we should maintain a constant good anterior chamber by constantly injecting the OVD and the add of sculpture and the add of irrigation aspiration. I mean, we have seen in the video before to go out of the eye, the handpiece or the eye we should make deeper the anterior chamber by injecting the OVD. Sometimes, despite all this measure taken, the capsular bag is clearly damaged, and it is necessary to act quickly in order not to aggravate the situation. The measures to be taken are as follows: avoid a flat anterior chamber by injecting OVD, and using and injecting a CTR capsular tension rig as soon as possible and in the correct side. I mean, all the time we should inject the CTR in front of the weak zone of the back, as I show in this video. The choice of the intraocular lenses is imposed of the state of the back and the zonula. I personally advise in this situation to use the 3 pieces IOL MA6C. This kind of IOL we can use it in and put it in the bag or in the circus, and even we can use this IOL by scleral fixation. The take-home message is that in this kind of surgery we have to be able to be faced to some complication, and the situation of this kind of surgery. We have to take caution before the surgery, during the surgery, and after the surgery. Before the surgery, we should be prepared to and able to face up of those 2 elements: poor iris dilatation and zonular weakness. During the surgery, we have to maintain anterior chamber stability by using OVD and to maintain very good iris dilatation, more than 5 millimeters, to do gentle hydrodissection, and in some situations to avoid to do a nucleus rotation. After the surgery, the follow-up after the surgery is essential, and we should focus on the eye stability and inflammation and the eye pressure. My take-home message at the end: this situation, I mean cataract and pseudoexfoliation, it's a very challenging situation, and it's really very risky surgery in risky eyes. Caution should be taken before the surgery, during the surgery, and after the surgery. And in these cases, all information and all scenarios should be given to the patient. And at the end, I would like to thank again all the Mayom Academy and wish you welcome to our meeting in Rabat at December. And before this meeting, of course, we have appointment together to the next Mayom Academy in October. Thank you very much, and see you soon.
Thank you very much, Dr. Mohsen, for this excellent presentation and very nicely showing all the steps for this critical, actually, situation that we are facing most of the time. I think we can go to any questions. Is there any question from the attendees here? We didn't receive any questions, so I will start with Dr. Abdurrahman. Dr. Abdurrahman, you present a very nice topic as usual, but if you want to summarize in 2 words, what is the message, the key message in this presentation?
In 2 words, we are doctors, so we have to, when we speak to the patient, we have to know exactly what's his demand, what's the problem. And after that, we have to choose the good hours for each patient. And now we can choose and we can have a good, precise vision after cataract surgery with premium IOLs. And we have to choose which IOLs for which patient.
In another things, well, also there is something, I mean, for example, we are as a doctor facing some patient, they are highly demand. And at the same time, they are having something like, you know, in another presentation, as Dr. Khalid mentioned, high myope or very high, I mean, hyperopic patient with small, short eye. So how you can manage in this way in passing the message for this patient?
Yes, of course. Of course, we'll have to take account some individual specificities for each one. And for high myope, for example, for me, I don't use multifocal lens, either no toric lens for high myopes, because the lens is not good centration, and you have the big capsular bag, they can make rotation. For hypermyope, they are very happy with multifocal lens, for example. So we have to take account some specificities, anatomical specificities, and we have, of course, we have to take also for our experience with each lens. But in general, essentially, I am very happy with the premium lens, and also I am very happy with the Variant platform. I am not using Callisto platform yet, but I think that it will be like the Variant platform. It's very precise. We can have a very predicted acuity, visual acuity in post-op.
So now we can say the cataract surgery is not a normal surgery as we used to say before.
Yes, it's not normal surgery. And there's a point, very important point, we have to be honest. Sometimes we have some complications during surgery. So if you have, we can change the strategy during surgery for piggyback IOLs, for artisan lens, for subluxation lens during surgery. We can choose to put another lens, but no problem. We can propose to the patient the bioptic treatment with the refractive laser surgery after. But before surgery, we have to make a good planification, and we have also to have a good acquisition of all the exams to have the good choice. And you know, if we make the good indication, we have less complication.
Thank you very much, Dr. Abdurrahman. Dr. Khalid or any others, I mean, Dr. Mohsen or Dr. Khalid, if they have any questions for Dr. Abdurrahman.
I have a question, please.
Yeah, please, Dr.
For Abdurrahman and for the panel. My first question, do you have any experience about multifocal IOL in childhood and for kids? And the second question, we have many patients with one eye surgery with monofocal IOL. They are not happy. Can we plan for multifocal IOL in patient with monofocal in one eye and multifocal in another eye?
Personally, I prefer to do multifocal in both eyes and in the short time, 3 days before surgery. And multifocal for me is not for child, because child change their vision with growing. So it's for hypermetrop, hypermetrop, and less not good high myopia. But two eyes with the multifocal, not only one, not monofocal, not mix and match with the monofocal. If you have a patient who is not happy with monofocal lens, we have to make the good question why he's not happy. And we can change the lens in the same month. We can change the lens easily, but no, I prefer multifocal in the both eyes. I'm very academic, both eyes, and monophthalm, of course, why not? But both eyes, not one monofocal and other multifocal.
Can I have a question?
Yeah.
If you have a chap like 30 years and he came with a cataract in one eye and the other eye is normal and he can see near, do you recommend multifocal for him or trifocal for him?
No, if he have only one cataract, unilateral cataract, he's 30 years, I will do monovision and with the monofocal lens with a little myopia, microvision, minus 1.25 or 1.50, and he will be very happy to see to see for reading. Or I will put sorry, this is case for people who are over 45 years, but he is less than 45 years. I will do emetropia lens with monofocal lens. Now we will see the near vision with the other eye, though no problem, monofocal lens. Because we have to take account with the quality of vision. And monofocal, we have a good quality.
Thank you.
Okay, so now for question for Dr. Khalid. Dr. Khalid, okay. If we want to summarize, so your advice, what is the best formula for long-sighted, and what is the best formula for long-sighted?
For me, I usually depend on the Barrett formula, because Barrett formula is a very good formula, and it's just one formula that you can use in different eyes, so that you do not want, oh, I will look at the biometry, check the biometry, and then I check which formula to use. Barrett formula is in general is the most consistent formula in different situations: long eye, short eyes, long eye with short anterior chamber, short eye with long anterior chamber or deep anterior chamber. It's the most consistent formula. So I usually recommend Barrett formula in different scenarios, because it performs well in these different formulas. The problem is the very short eyes. The very short eyes, we still get some surprises. So I may use Barrett formula, I may use the Kane formula in these eyes, or we don't have the lens star, but the Hill RBF3, where they add a lot of eyes with short axial length, also performs good. So Barrett formula is a very good formula. If you want to also to add another formula, maybe Kane and even Olson perform well in long and in short eyes.
Any question from Dr. Abdurrahman or Dr. Mohsen for Dr. Khalid?
Any one question, please?
Yes.
Yeah, please.
Dr. Khalid,
أهلا.
أهلا بك. You highlight a very important point to focus about anterior chamber depth when doing biometry. And I share with you, I agree with you totally, we can have high myopia with anterior chamber very small. In which cases you will be to do laser iliac iridotomy before to do surgery, which the amount of the anterior chamber you will that the surgery will be very risky in a small anterior chamber.
Actually, I don't do peripheral iridectomy even in very short eyes, because once you remove the lens, even if the axial length is 20 or if the anterior chamber depth is 1.7, last week I had a case with a 1.7 anterior chamber depth, and the second day after we removed the huge lens, then the anterior chamber came deep. So usually after surgery, these eyes get a deeper anterior chamber, and now one of the treatment options of angle closure glaucoma is to remove the lens, even if it's a clear lens, because once you remove the lens, you debulk the anterior chamber, you will get a deeper anterior chamber. So routine, I don't usually perform. This is for my experience. I usually do not perform peripheral
We have
iridectomy.
a short time, so because the second session it will start. I don't want to interrupt you, but we have 1 minute, so we will. If you have a short answer for any questions, we have also one question to Dr. Mohsen regarding: is there any, a very different categories for pseudo exfoliations, or they are all the same, whatever the pseudo exfoliation you are seeing?
No, certainly not the same. I think the bad situation it's pseudo exfoliation with meiosis. When with dilatation, it's very poor. It's like we told for young ophthalmologists, small dilatation, big problem.
Yeah.
Any other question from Dr. Mohsen?
Mohsen, one question. What do you think about hard cataract and syndrome exfoliative? I think to have a hard cataract, very hard cataract, it will be a more problematic than normal cataract with exfoliative syndrome. I think
sure.
Yes.
That's why I focus about the endothelium. We have to keep in mind that hard cataract will be very long time surgery, and we have to keep in mind which the amount of endothelial cells, and in some cases not to be to go directly to extracat.
Can we have one question to Dr. Khalid? We have time?
Please. Okay, yeah, we have only a few seconds, please.
A few seconds. Dr. Khalid, thank you for your presentation. As I told before, for high myop, I avoid toric lens and multifocal lens, but from time to time, some patients are demanding to have precise acuity with toric lens. So in this time, I have a look on the thick lens, crystalline thick lens, lens thickness before surgery. If it's less than 4 millimeter, I can do toric lens.
Toric lens. Yeah.
I will have an idea about the capsular back. That is my idea. Is it true what I'm doing or not? Do you have an idea?
Okay, we are almost done. Within 1 second, Khalid, yes?
1 second, yes. I think with the new formulas, they are performed very well, even with toric IOLs. But in these situations, you need to worry your patients that the outcome might be not as expected, but usually they will get a very good outcomes, and they will be very happy, even if they have even 1.5 diopter of astigmatism at the end. They will be very happy, these patients.
Thank you very much. Thank you, Dr. Mohsen. Thank you, Dr. Abdurrahman. Thank you, Dr. Khalid and Dr. Walid, for these excellent sessions. We hope to see you in the other or in future And we are going to conclude and pass the mic for Dr. Barol. She will start the glaucoma in this hall. Thank you very much.
Thank you very much. Thank you all. Goodbye. Take care.
Thank you. Bye.